Our next speaker is Peter Bergold.
Well, I'm glad you all got woken up by the last talk, so I don't have to do it. So I'm going to be giving you a snapshot of the work I'm doing today on traumatic brain injury, and I'm going to talk about 3 independent projects in my lab. And so I'd like to introduce by saying one of the real paradigm shifts in the field of TBI in the last 10 years. It was very much appreciated that TBI used to be considered an acute disease. You acutely damage the brain, bad things happen for a couple of weeks, and that's it. But now it's very much more understood that TBI can be chronic, and there's chronic atrophy of both gray and white matter. There's chronic inflammation that can go on for years, and there's increased risk for a variety of neurodegenerative diseases. And the one that's most prominent in the epidemiology is Parkinson's disease. Now, the reason why this paradigm shift occurred was not because of a form of TBI that resulted from multiple mild or subconcussive injuries called chronic traumatic encephalopathy. And this was and we all know that this was occurring in people with contact sports as well as in the military. And it's characterized by neuronal and astrocytic tauopathy, and that was fascinating because this was an example of a protein that we knew that was implicated in Alzheimer's disease, but now was clearly being triggered by brain injury. But one thing that's just simply not known is what happens if you get one TBI, one moderate to severe TBI, as opposed to these multiple mild or subconcussive injuries, and that's one of the things that we've been studying. So what we found was we could injure animals, and because of COVID, some of these animals got stuck into the animal facility for 6 months and we didn't look at them. And when we took them out and we put them into MRI, we found that there was substantial gray matter atrophy, and this was acute but not progressing. So if we looked at early on in animals, you got this gray matter atrophy, and it just didn't change. But what was striking is we saw a tauopathy. And we saw a tauopathy that occurred early, and interestingly, it was very different than chronic traumatic encephalopathy because it was found exclusively in oligodendrocytes. And what we also are finding now in our more chronic animals is increase of amyloidogenic aggregates. And I'm giving you a lot of preliminary stuff. We don't know what this is yet, but there's a stain called thioflavin S, which stains amyloid structure, and it's filling up the thalamus of these animals. So that's one thing that we're studying. But the other thing we found is there was white matter atrophy. And there was 2 types. There was one that was acute and non-progressing. So we'd find it early, and when I said it doesn't progress, we were doing both T2 MRI and diffusion tensor MRI. And the diffusion tensor MRI gave all the parameters that people have seen in TBI. Bad things are happening in the microstructure, and between 14 and 6 months, nothing changed. But then the other type of atrophy we saw was delayed and is progressing. So it wasn't there at 14 days. There was substantial white matter atrophy at 6 months. But the fascinating thing was diffusion tensor parameters, which are a measure of white matter microstructure, was not changing. So we're losing tissue volume, but we don't know exactly what's going on in there. And that's another thing my lab's beginning to study. And what was interesting is we also saw an accumulation of tau in oligodendrocytes. But in this case, in this slowly atrophying white matter, it kept on going up. And so that's another thing that we're studying, what's happening. Okay. So that's one project that's going on in my laboratory. Now, there's another thing that came out of these chronic animals that was really striking. And so, as I said, TBI, one of the risk factors is a Parkinsonian-like symptoms. And we're also seeing in our MRI studies chronic atrophy in every structure that's involved in Parkinson's disease. Substantia nigra, globus pallidus, caudate putamen, internal capsule. And we're also seeing dopaminergic neuronal loss in the substantia nigra pars compacta. We are also seeing accumulation of alpha-synuclein in internal capsule and the substantia nigra pars reticulata. And the other thing that Sirvan Lawless in my lab has been studying is she's been developing using a machine-based method called deep lab cut And in this, we were finding chronic progressive motor deficits in these animals. We were seeing slower initiation in open field. We were seeing increased turning toward the injured hemisphere. We were seeing impaired vestibular functions, all of which are characteristic of Parkinson's disease. And so we're very excited about this because this is the first model, if it's true, this is the first model of Parkinson's disease subsequent to a single injury in a rodent. Okay, so now to give you the last study that we're doing in the lab is something my lab has been studying for many years, which is therapy. So we've been, long ago I got a DOD grant to look at drug combinations to treat TBI. We combined two FDA-approved drugs, and we found long ago that the combination of minocycline and N-acetylcysteine, both two FDA-approved drugs, synergistically improved a variety of therapeutic outcomes after TBI. This has been many years of study. We've seen that this improved. So most importantly, TBI is not unlike stroke. You have to get the drugs on fast, and because TBI is acute and the injury develops very quickly. But we were able to show that we could have a therapeutic time window of up to 12 hours after injury and still maintain good efficacy. And so that was very, very helpful in terms of clinical trial development. We also showed it improved behavior. We showed it improved electrophysiology. For example, the long-term potentiation that has been described by Todd Sachter and Panos Soukas. And interestingly, one of the targets that this drug improves is the enzyme they were discussing, protein kinase M zeta. So this increases protein kinase M zeta. It protects neurons. It maintains synaptic density. It has a very interesting modulation of acute inflammation. Both these drugs are anti-inflammatory, but very soon after injury, they're actually pro-inflammatory, both for pro-inflammatory and anti-inflammatory microglia. And so, but most importantly, most recent studies have shown that we can dose these drugs 12 hours after injury and 3 days later take plasma biomarkers. And one plasma biomarker we found is it lowers the level of total tau, which gives us an objective biomarker for a clinical trial. And I've been working with Steve Levine, who you just heard with, and the NeuroNext network on the development of clinical trials. So let me just end by thanking the people who work in my laboratory. I've been very, very blessed with wonderful people. I've been very fortunate to have very good collaborators at Mount Sinai. John Crary, who's a former MD PhD at Downstate, is a head of the neuropathology laboratory there and has given me endless help in terms of neuropathology. Alan Seifert has helped with the radiological studies, and the biomarker studies are being done in collaboration with Kevin Wang. Thank you.